Hello, everybody. My name is Kyle King, and welcome to the IOCDF Research Roundtable, the show where we look at a hot topic in the OCD literature and discuss it with people who know a lot about it. Today, we're going to I should probably introduce myself. As I said, I'm Kyle King. I'm a research assistant at the Yale OCD Research Clinic. I'm also a student here. I'm a senior now. All the med school applications are in. I'll keep you guys posted month by month. And I not only research OCD, but I have it. So a lot of these conversations are really personal to me and mean a lot. And as always, I'm joined by my co-host and somewhat of a panelist this time, John Abramowitz. John, if you'd like to introduce yourself.
I'm Jonathan Abramowitz. I'm a professor at the University of North Carolina at Chapel Hill, and I conduct research on OCD, work with folks who have it, doing treatment, teach the clinicians, the psychologists of tomorrow how to understand and treat OCD and other related things. And I am very pleased to be here, as always.
And there's also a guest who also is a research assistant at Yale, a friend of mine, Liz, who knows a lot about the topic we're going to be discussing today, which is suicidal obsessions and suicidal ideations and how those two are similar and how they're different. But before we get into the meat of that topic, I do have some announcements that I must say. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. This topic of today's live stream is in honor of Suicide Prevention Month. It's a little heavier than a lot of our other topics, so please do not hesitate to reach out to those resources. We also want to create a safe space, particularly for a topic like this, and there's a live chat. Me and John love it when you put questions in the live chat, and I'll definitely try to get to as many of them as I can throughout the live stream. Just know that whatever you put in there lives on the internet forever, so please be mindful. That's all. All right, then.
Do you want to say something about next month? Because we have a very special edition of the Roundtable next month for OCD Awareness Week.
Yeah, as I believe I read in one email one time, the next month's edition of the Research Roundtable is going to be kind of like me and John acting as mythbusters of sorts, kind of picking apart some common myths about OCD. John's going to tackle it from the research side, and then I'll throw in my perspective as someone with OCD to see if those myths kind of align with how I've experienced the disorder. That sound about right?
Yeah, I'm very psyched for that, and I know folks aren't going to want to miss that one.
Yeah, I'm probably going to talk a lot. There are some misconceptions about OCD that bug me.
Same
but
here.
Anyway, so our guest today is Elizabeth Matura. I've never said your last name, Liz. I've never called you Elizabeth either.
There's a first time for everything.
She's a research assistant at the Yale OCD Research Clinic and the U.S. Department of Veterans Affairs. At Yale, she studies the cognitive, affective, and behavioral differences in suicidal obsessions and suicidal ideations. And with the VA, she supports suicide prevention research. Liz, how are you doing?
I'm doing great. Happy to be here.
Awesome.
Yeah, I'm particularly excited for this one because I have a friend who went to an OCD specialty clinic and was discussing legitimate suicidal ideation, and he was misdiagnosed as having self-harm OCD, and his treatment plan went awry for months because there's a misattribution or a misunderstanding of what was going on in his head. So I've seen firsthand how confusing these two things can be bad. So the first thing I just wanted to ask you, just definitionally, what is like the definition of a suicidal obsession versus a suicidal ideation?
Yeah, so suicidal obsessions, just like any other obsessions in OCD, are going to be those unwanted, intrusive, distressing thoughts of whatever the content of the obsession. So in this case, it would be suicide or self-harm. By contrast, suicidal ideations are going to be potentially more desirable thoughts of suicide, but not always. Maybe an affective affinity towards suicide, egosyntonic thoughts of suicide. That's more of the classic thought of suicide that I think, tend to think about.
Mm-hmm. So when they pop up, it's more like, oh, I'm in a low place right now, and this isn't striking me as like, oh God, when suicidal ideation pops up, that is.
Yeah, so sometimes we might think about, those with suicidal ideations may think, I wish I were dead. I wish I weren't here anymore. I wish I could go to sleep and not wake up. By contrast, again, with suicidal obsessions, it's more of a question. What if I die? What if I do this to myself? What if I hurt myself? Then what? So there's a lot more uncertainty associated with it.
And in a very, like, you mentioned egosyntonic, which for folks who aren't familiar with that language means just kind of consistent with how you're feeling at the moment. In OCD, it's very ego dystonic. So it's like, I don't want to commit suicide. I'm afraid to do that. I'm afraid I'll lose control and act on my thoughts. So it's because people who have actual suicidal ideation sometimes think about what if, I do it. But in OCD, it's just not consistent with how you're feeling. It's the last thing you want to do. And, and so you're scared of thinking that in a way that a person with suicidal thinking doesn't have.
Well, and so it's tricky because sometimes those with suicidal ideations, I think, can have that similar fear. It's not quite to the same extent, I don't think. But sometimes there is, I wish I could go to sleep and not wake up, but I don't know if I want to die. Or I definitely don't want to die by suicide, but I wish I just wasn't here anymore. And so sometimes it gets really tricky. And Kyle, that example that you provided is not uncommon, but I think less common than the other way around, where someone with suicidal obsessions is mischaracterized as having suicidal ideations, which has totally different treatment implications. So it's interesting. It's tricky.
Mm-hmm. Yeah, the egosyntonic, ego-dystonic distinction does seem a little tricky to me because, I'll say I've experienced suicidal ideation, and I don't enjoy that those thoughts are coming into my head. They're not pleasant to have, just as my obsessions with OCD are.
I think everybody at some point has suicidal thoughts, right? Even though it's not, and sometimes they occur in the context of what if I just lost control and did it, because you hear about someone who did it. And then sometimes they occur in the context of, I'm feeling really lousy. What if I didn't wake up tomorrow? And I think it's pretty human to have both of those kinds of experiences, which can make it challenging to figure out what's what. I don't know, Elizabeth, you're the expert on this, but to me, kind of clinically, in the majority of cases, it's not that hard to figure out if it's egosyntonic or ego-dystonic, but certainly there are some times when it can be difficult, and certainly for a person going through it, especially if they have OCD, right? With all that need for certainty. Oh no, how do I know which is which? Probably a lot of rituals around figuring that out, trying to figure it out.
Right.
Well, John, you go, Liz.
No, I'm sorry. I was going to say sometimes you might even see some of those compulsions of checking with their clinician. Is this suicidal ideation? Do you think I'm going to hurt myself? Are you sure I don't need more intensive care, just to be extra safe?
Yeah.
To kind of set, I want to pick this conversation up a little later, but I want to set the stage for just the broader discussion. What is the prevalence of suicide in people with OCD? Is it comparable to other disorders?
So, to my understanding, it's a little lower than other disorders. I'm thinking of one particular article that I read. I think it's roughly 30% of inpatients with OCD have had past suicide attempts, which is high. But again, those are inpatients. So that's a much more severe population, potentially with other comorbidities and so on. Compared to other disorders like substance use disorder, some personality disorders, mood disorders. In those disorders, you would see a much higher rate of suicide, I think.
And is the rate of suicide in people with OCD in general, does it increase in people with this sort of suicidal obsession?
So There's very little research on suicidal obsessions
Okay.
as is. I would anticipate you might see the opposite, but again, it's just so under-researched that I can't say for sure.
I would agree with that too, but yeah, I mean, it's.
John, why do you nod your head? Like, what's your?
Yeah, I mean, I think those are the folks who are like extra, and you know, one of the questions I know we're going to get to is like, you know, why this type of obsession? So we can kind of dovetail into that. We know that people have obsessions about particular topics for the most part because those are the very topics that are especially important to them, right? And so if you have suicidal, you know, obsessions, self-harm obsessions, that's like the last thing you're going to do. And so my guess is that that is kind of what Elizabeth is getting at, is that there's those are the people who are the least likely to commit suicide, and that's part of why they're having obsessions about it. Would be my guess, but again, that's just a clinical observation. I don't know, Elizabeth, if you feel like that makes sense.
Yeah, I think I agree. But again, it's so understudied. So I've recently started studying suicidal obsessions, and there's very little literature on it. So it's hard to tell.
Yeah. I like the reason I kind of thought of that question was because I would imagine going to your clinician and saying I'm having these persistent thoughts of suicide is uncomfortable. And with any one of those more taboo types of OCD, I would imagine there's less disclosure, and that could lead to something like increased suicide rate. So is like, I guess we consider, do the more taboo subjects have higher suicide rates, or like worse treatment outcomes potentially?
So that's one of the really tricky things, is that we currently cluster suicidal obsessions with other harm, unacceptable, taboo obsessions like harm, you know, fear of harming others, sexual intrusive thoughts, religious thoughts. And those are the types of topics that typically have the higher rates of suicide. I imagine just because there's so much shame associated with it. But like we were just saying, I think suicidal obsessions are going to be a little bit different. And so maybe it's best that we don't classify it with the other unacceptable or taboo obsessions.
That's a good point.
Mm-hmm. John, in your clinical experience, have you noticed, like, I guess, differences in treatment outcomes with those more taboo symptoms, or like differences in how people approach talking about them with you?
Well, people, you know, it's definitely harder to talk about those kinds of unacceptable, taboo kinds of thoughts that Elizabeth's talking about, as you know, as opposed to contamination and checking and stuff like that. Just because, you know, yeah, they're not taboo; they're socially more acceptable. As far as treatment goes, if you can get, you know, if the person is willing to talk about it and do all that, we can certainly do exposure and response prevention for those types of problems and act. It used to be thought that those kinds of obsessions did not respond as well, but I don't think there's data to suggest that now. I think it's pretty clear.
Why? What was the thought?
The thought was that those folks didn't have behavioral compulsions, that they had mental rituals, and that somehow mental rituals, or, you know, pure obsessions, were somehow more treatment resistant. And we know that that's not true. And there really isn't a thing called pure obsessions. Those folks have compulsions. They're just often more covert mental rituals, or more covert strategies like avoidance and thought suppression and stuff like that. And if we know about them, if we know to assess them, we can treat them the same way we would overt rituals with, you know, good ERP is the best treatment.
I would also anticipate that the ERP for some of these unacceptable or taboo obsessions would be really challenging. And some clinicians may not know how to approach those kinds of exposures.
Yeah, may not know, or may feel uncomfortable with, you know, here's a knife, you know, and let's talk about hurting yourself or hurting the therapist or something like that. Yeah, those are more challenging to do. But they're equally as effective, sometimes if not more effective, because they're very, very clear demonstrations of, okay, I can think about harming myself, I can hold a knife or a pair of scissors or something like that, and learn that I'm safe. These thoughts don't mean what I'm afraid they mean.
Mm-hmm. Yeah, I was going to ask, it seems like tricky to do exposure therapy with something as like serious as a suicide, but you put someone in a situation where like, I guess it's possible, and then have them evoke the thought that like they might do this right now.
Exactly. And so there, you had two questions there. The first is, obviously from the clinician's point of view, you want to make sure, right?
Yeah.
Not sure, right? Because we don't have 100% guarantee, but you want to be careful.
Pretty damn confident.
Pretty damn. That's a good way to put it. Pretty damn confident that you're dealing with an obsession rather than actual suicide intent. And there are ways, as psychologists and as mental health professionals, we have good ways of assessing. Not 100% perfect, but again, I would argue that nothing is. But beyond,
I'm asking a bunch of questions about that later. Don't you worry.
All right, cool. Yeah, but beyond a reasonable doubt, yeah, that's what you do. You would have them, and I've done this before many times. Whether it's someone with thoughts about harming themselves, thoughts about harming others. Here's a knife. Let's think about this. Maybe we start with just thinking the thoughts, and the knife is over there somewhere, and then we gradually bring the knife closer, and then it's sitting there on the desk, and you're thinking about harming yourself, and then you're holding it, and you're thinking about harming yourself. And the idea, experience is the best teacher. You can talk to someone, oh, you're not going to harm yourself. But until the person has a chance to actually do an exercise like that and repeat it over and over again, when they do that, they have a chance to learn, oh yeah, these thoughts they're noise. They're not really, something that I have to be afraid of. And these situations, these thoughts are safe. So yeah, it sounds scary, and it is. Doing exposure therapy can be scary, and that's the point, is to learn that you don't have to be afraid of these things. But that's what we do, and it's very effective. People learn really quick. Oh wow, I didn't realize that. I've been avoiding knives and trying not to think about this stuff for so long, but actually I can, and I don't like it, but it doesn't mean that I'm dangerous.
Mm-hmm. Liz.
I was going to ask Dr. Abramowitz if you
Please.
Could speak a little bit to the differences in reassurance seeking and exposure therapy for something like this. When someone has that thought, what if I hurt myself? And you mentioned just saying, well, you're not going to do that, don't worry about it, compared to them realizing it for themselves.
Yeah, I think in reassurance seeking, what the person is doing, it's the person asking the question. Do you think I'm going to do this? Do you think I'm going to, harm myself? And with exposure therapy, they're learning that by their own experience, in a way that they haven't done before. So it's new information for them, rather than they're being told the same thing, over and over again. So right, a lot of people who have these kinds of suicidal obsessions, they might ask doctors, they might ask mental health professionals, they might ask other people, am I going to hurt myself? Do you think I'm going to hurt myself? And they probably know what that person is going to say, right? Mm-hmm. They probably know that the person is saying, no, of course you're not going to do that. But they're still afraid of the situation. And that's because they haven't actually been they haven't had that experience where they're having the thoughts, they're in proximity to something they could use to harm themselves, for example, and they get a chance to really see for themselves, I'm actually not a threat to myself. These thoughts are not the same thing as being a threat to myself. Excuse me. I'm getting over a cold. Not COVID, but a regular cold.
Yeah, I'm thinking back to all the times I've asked for reassurance with my contamination OCD, and I always knew exactly what the person was going to say, and I knew the answer. I just wanted to hear them like verbalize what I already knew.
Exactly. Yeah.
But John, I guess kind of this is more like a general treatment question. Are you more in favor of like just kind of skipping the talk and getting right down to the exposures? Because that's what it kind of sounds like when you're treating something like self-harm OCD. I don't know if you can call it self-harm OCD. I don't know if that's like an accepted term.
Yeah, I don't know. I would just call it obsessional thoughts about, harming yourself. But no, I think there is a lot of work that's helpful to do to set up an exposure like that. So when I work with folks, I pull a lot from ACT, from acceptance and commitment therapy. And there's a lot of really cool strategies derived from that to help people to understand the process of their thoughts. When you have a thought, like, a thought to stab yourself, I'll just say that.
Mm-hmm.
We can look at that from different ways, right? We can look at the text of that. What if I stab myself? And those words are really scary, right? When you put them in that order, and you're someone who doesn't want to do that, right? But that's only one way to look at the thought. Why do people have those thoughts, right? We can look at the process of why that thought is coming up. And it's kind of like what we were saying earlier. You're thinking about that because that's the last thing you want to do. You're thinking about that because you're spending so much time trying not to think about it. So there are some good reasons for why that thought is coming up that have nothing to do with, the text of it. They have nothing to do with whether or not you're actually dangerous to yourself.
Mm-hmm.
What we want to do before we do exposure maybe is help people to start to kind of see those thoughts for what they really are, rather than what they're kind of yelling at the person, and not to take them as facts. So I usually use that as kind of an introduction. There's some metaphors that we like to use. We can talk about those if we want. And then once the person is able to understand, oh yeah, there's something to that. Here are some good reasons why it would be helpful to take the next step and confront my fear. Then you
go ahead and do it.
Do exposure, yeah. Just we never dragged someone into exposure without their consent, and this is hard things to do. So we always talk about it, up front for sure.
That kind of segues into a question Amy just asked at 1219. What's a good way for a peer leader of a support group to help someone with suicidal OCD, especially if they have a therapist who doesn't specialize in OCD?
I think that if it's a support group and not a treatment group, I think there are lots of different things that can be done. So we're talking about things besides exposure therapy. I think some of the techniques I was talking about from ACT, so being able to see your thoughts, being able to consider that maybe your thoughts are not just facts, right? What are some other ways to think about them? One technique that is often helpful is to have people put like a phrase before, like verbalize the thought and put a phrase before that. So instead of what if I hurt myself, it could be like I'm having the thought, what if I hurt myself, right? Or there's that old idea again, what if I hurt myself? To kind of decontextualize it and get some distance from it. There's also inference-based cognitive behavior therapy, ICBT strategies that help people to see some of the logical errors, some of the reasoning errors that they're making when it comes to these kinds of thoughts, and where they get the idea that these thoughts could be true. The evidence that they're using is not is not based on the here and now. It's more based on their imagination of things that they could do, as opposed to the facts about, you've had these thoughts lots of times. You haven't done anything in the past. You don't have the intent to do anything. And so there are lots of different strategies that folks can use to try to manage these thoughts outside of exposure, for good support.
Mm-hmm. You're saying like putting I am having the thought that X brings me back to the good old days of ERP.
I hope that was another one that I like is the the bet. What's the
bet?
The life savings bet, life savings wager. Right? Would you bet me the entire King life savings that you're going to commit suicide? Right? And hopefully you would say, no, right? And then I would say, well, why?
Why? Yeah.
Right? And then you would give me reasons for why you're not going to commit suicide. And that helps you to start to think, in a less obsessional way about this. And again, that can be a way to kind of distance yourself from these kinds of thoughts.
It's like Jonathan Grayson's, like, if I put a gun to your head and asked you if this is real.
Exactly. Except for a suicidal obsession person, I wouldn't use that.
That's a good catch. Look, I'm still an undergrad, John.
and especially with all the gun violence and stuff. I don't like the gun. He calls it the gun test, which in theory it's I love it. It's great, but I don't know. It's a little more violent than the life savings wager. So that's just my preference.
Fair enough. I also like that Liz called you Dr. Abramowitz, and I don't think I've ever called you that.
My dad is Dr. Abramowitz.
I just like casually throw like, good-natured insults at you the whole show.
And I take them with a
You
great
take them okay. I did want to ask John, like, I can imagine, like, my parents suffered a lot when I was going through my contamination OCD, and I can only imagine if your son's coming up to you and saying, I really don't want to kill myself, but I'm scared I might kill myself. Like, that must be incredibly distressing from the family's perspective. So how does a clinician speak to a family, or do they bring in the family, or what do they tell the family about this sort of thing?
Yeah, I don't know, Elizabeth, do you want to, I guess you're a research assistant, so you probably don't have a ton of clinical experience, but if you want to,
right.
I don't want to monopolize the conversation.
No, please.
Okay. So Kyle, back to your question. So you're talking about someone who has some other form of OCD, but they're talking about suicidal thoughts.
Yeah.
Yeah. Well,
oh no, I'm talking about suicidal obsessions. Like, if I went home and told my mom, "Oh, John today had me hold the knife and think about killing myself," I don't think my mom would love to hear that.
Oh, I see. Well, the hope would be that you would then educate your mom, or maybe have her even come to a treatment session to learn about why that's actually helpful, and how that, leaning into those kinds of thoughts and experiences, if they're true obsessions, is going to help you to actually reduce them, and more importantly, reduce the way you respond anxiously to them.
Do you find that patients will go and tell like their family, or do you normally bring in a family and speak to them?
A little bit of both, actually. And then some folks don't want to say anything to anybody. It's their own business, and so really, yeah, it could go any different number of ways.
I would anticipate it's also helpful to have family involved in the process, in the sense that, if somebody's coming in to say, I'm having these thoughts of hurting myself and I'm doing exposures with my therapist, but then I go home and I'm still asking my partner to cut the vegetables for dinner because I'm afraid of holding the knife. Maybe it could be helpful to have, your partner encourage you to engage in exposures more frequently when you're at home too.
Amen. Yeah. We call that accommodation, and absolutely we want to help folks to reduce that. Good call.
Yeah. Are there kind of like common, you mentioned cutting the vegetables, and I've heard that come up a couple times. Are there kind of common like scenarios that people with this sort of OCD might fear, just so that like if someone's watching and maybe resonates with this, isn't sure if they could identify or see something in themselves that maybe you guys have seen a lot of times?
I've seen a lot of, or I've heard a lot about, what if I drive my car into the other lane, into a tree? What if I stab myself? If I'm shaving, what if I cut myself intentionally? What if I take too much medication when I'm taking my, even my antidepressants or an Advil or whatever? So
it's pretty
it
everyday
can manifest
stuff,
in a lot of
just
ways.
It's like everyday stuff taken to the extreme, basically. Like,
but just like it was mentioned earlier, with the fact that these thoughts are so common and they can come up across the board. So I've used the example myself that was not, I'm not somebody who's had OCD, but I've had intrusive thoughts before, and those aren't uncommon. So I use the example, my freshman year when I was, hiking a mountain near my school. I remember looking over the edge and having the intrusive thought, there's no railing there. I could jump off. And that's really scary. And so I backed away slowly, and it didn't cause me a ton of distress later on, but it was kind of a spooky thought to have in the moment. And so I would imagine someone with OCD may, latch onto that thought and continue to ruminate about it and continue worrying, what if I do that? What if I go back there and do that? So it can be about anything, I think.
Yeah, I can tell you, as someone with OCD, I'm phenomenal at ruminating. It's like probably top 3 skills of mine. Okay, Liz, I'm going to switch over to start grilling you, because this whole discussion has been contingent on the idea that you can differentiate these obsessions from these ideations adequately. So
We'll see.
So we kind of established the definitional difference at the offset, but I'm imagining it's difficult to, in practice, figure it out. Actually, I want to go to John first because he said he's pretty good at differentiating obsessions from ideation. So John, what kind of tips and tricks might you use?
Yeah. So first of all, I want to know about like history of suicidal thinking, and certainly if they've got a plan, like how would you do it? What's your, I want to know about their mood. Are they feeling, bad about themselves? And again, all of these can be, all of these can be part of OCD as well. But history is good. How do you feel about these thoughts when they come up? What do you do when these thoughts come up? People with OCD, when they have intrusive, unwanted thoughts, obsessional thoughts, they do rituals. And so I'm looking carefully at the kinds of responses that these folks have about their thoughts and their interpretation of the thoughts. And so again, if they're saying, no, I don't like having these thoughts, and I do these rituals to get rid of them, and I ask people for reassurance, and I'm not going to do it, and they're doing that a lot, I'm going to lean towards the OCD side. But if they're saying, yeah, I I do feel like I really could do this, and I have a plan, and I even try, if they've tried it actually before, again, it doesn't mean it's not OCD, but more likely, yeah. And so again, we're talking probabilities here, but you, as with anything, but you do have some ways to, to figure out, for the most part, is this something that I want to be concerned about and maybe, look more carefully about, or can we kind of say, okay, this is OCD. It's an unwanted thought. We don't have to be concerned about suicide.
I'm curious about, so with the overlap of somebody who have both, that's always been really challenging for me to distinguish. And I'm imagining there's other scenarios when it's especially difficult. I'm specifically thinking, if I'm working with someone with OCD who has suicidal ideations, and it seems clear that these are ideations. For one of the studies I'm working on, I'll develop a Stanley Brown safety plan. And so within the first steps, you come up with things that you can do when you have these thoughts, to distract yourself, to lighten your mood, just something to do instead. And so I'm thinking of some of the examples, maybe you could take a shower, maybe you could listen to music, watch your favorite show. What happens when that becomes a ritual though? If someone has that intrusive, or even if it's just more of an egosyntonic thought, I want to die. And then they begin to engage in that cycle of, when I have the thought, then I do this thing that's on my Stanley Brown safety plan.
Yeah. Well, you're thinking really well. If it's a person with OCD, if it's a bona fide obsession, those things could turn into rituals. If it's a person who has bona fide suicidal ideation, it's good that they're doing those things because maybe it's, saving their lives. And we also want to get them some help so that it's not, so they're not thinking that quite so much in an egosyntonic way. I don't know if was that your question?
Yeah, that's helpful to think about. I'm also wondering if
those strategies could become rituals.
Yeah, that does blur the line if you have a safety plan and you default to that every time.
Yeah.
Right. And if somebody has OCD already, but they don't have suicidal obsessions, they have suicidal ideations, can they become obsessional in nature?
I see what you mean. Knowing what we know about OCD, that it is possible for folks to develop new obsessions, I would say that it is possible, sure. Yeah, you can have obsessions about about anything. And there are cases where someone hears about something and then that develops into an obsession. So I think that's the exception rather than the rule, but it certainly can happen.
Right.
Now, here's another thing that I don't have a guarantee about that's really important to me that I could do. And so I'm gonna, I'm gonna start to worry about that. I'm gonna try to get a guarantee that I'm not gonna do it. And then that just makes you think about it more, and the whole OCD vicious cycle.
Right, right.
And Liz, you published a cool paper last year that was kind of like helping to delineate between suicidal ideation and suicidal obsessions. It was one of the few papers that I could read and understand fully. It was very well written. And you kind of said that there's like cognitive differences, affective differences, and behavioral differences between these two things. So I kind of want to walk through that because I feel like it could be helpful. So what were kind of the cognitive differences first that you identified?
So cognitively, that's where we see that I think of it as kind of a spectrum between ego dystonic and ego syntonic. So how the thoughts are appraised, are they consistent with your sense of self? Affectively, there's less research there, but you may have some of those. You can ask questions about their affective response to the thoughts.
Yeah.
So, for example, just how does the thought make you feel? What types of emotions are associated with the thought? With OCD, with suicidal obsessions, I think you'll get more fear, more of that uncertainty, more negative affective responses. Whereas with suicidal ideations, it may be positive or negative affective responses, probably more positive, but again, it can span across that spectrum. And behaviorally, you would see, I'm sorry.
Are there like those like, are there, what sort of studies have done to prove that? Because that seems like a strange idea to me that someone have those thoughts and enjoy it. And yes, I know I'm setting you up for a study that you enjoy talking about.
Yes. So there are very little, again, there's very little research on suicidal obsessions. So that's the study that Kyle is referring to is a study that we're conducting at the Yale OCD Research Clinic, looking at differences between suicidal obsessions and suicidal ideations in those with OCD, and looking specifically at those affective differences using first-person suicide images. So this study is based off one that was done in Matthew Knox's lab at Harvard a few years ago, where they showed individuals with suicidal ideations images from the first person perspective that show or depict suicidal behaviors. And they found that those with suicidal ideations view the images as more pleasant, less threatening, and less arousing than those with no suicidal thoughts, the healthy control group. So I'm imagining those with suicidal obsessions would respond on the total opposite end of the spectrum, from the healthy controls even, that they would look at the images and say they're much less pleasant, much more threatening, much more arousing than even a healthy control would view the images as. So we've started to collect some of that data, and that's essentially what we're finding. And so this is the kind of the first look at some of these affective differences, I think.
That is awesome. Are you by any chance doing like psychophysiological measures like heart rate or skin conductance?
So not yet.
But Knock did, right?
No, so they didn't in that study.
Okay.
They do a lot of those measures though. And I've been talking with some of the other members of the clinic about maybe continuing this study and maybe getting some of that EMA data and collecting some of those physiological responses. I think that'd be very helpful. And also interesting just looking at the OCD specifically. Maybe just viewing the images in an EMA format when they're viewing them several times a day could be, kind of an exposure looking at the images. So I don't know.
Yeah, that's really cool stuff. I would hypothesize that you would get a higher psychophys, like more heart rate, skin conductance, like higher for the OCD group, because they're scared of those things. Whereas the people, if it's ego syntonic, if they really are thinking about it, it's just not as scary. It might be really distressing, but not going to be as scary as someone who has obsessions.
That's what I imagine. That's
Yeah.
what I imagine.
That's really cool, Liz. That's really cool.
Yeah.
Yeah.
I'm very excited about it.
you
Kyle
also-
knows I never stop talking about that study.
Did you propose it, or is it like, is there someone that you're working with?
No, it's kind of my baby. It's my baby project. So that's all I think about.
You're going to go to grad school one day, I assume.
Yes.
Yeah.
I'm applying this cycle.
Okay. You're applying this cycle? Oh, I'm not taking a student this cycle, but whoever ends up having you come to work with them, you're awesome. They're in good shape.
Thank you.
Yeah, that's a great idea.
Yeah, I'm excited about it.
Yeah. Uh-oh.
I think we lost Kyle.
Kyle frozen.
But like I was saying, with this study, I think moving forward, there's so many different directions. So we're kind of up in the air about what approach we want to take. I definitely would love to do something EMA based, but look at other populations as well. When we think about those who have these constant or more frequent thoughts of suicide, what does that look like? Maybe in first responders, just in other populations, it could be interesting.
Yeah. Oh wow, that's really cool. I'm impressed.
Okay, wait, am I back?
You're back.
A little bit, but you're back.
You lost me when I said all you do is insult me. What gives? You're being so nice.
Yeah, we were insulting you while you were stuck.
I would expect nothing less. You also in the cognitive section of that paper, you talk about content differences, and then maybe like clinicians could use the presence of other symptoms as a way to help delineate between SO and SI. So like, what are the content differences, and then what do you mean by other symptoms?
Yeah, so I'm thinking if you have other obsessions that may indicate, although of course not always the case, but it may indicate that this is more obsessional. Likewise, other harm obsessions. So I'm afraid I'm going to stab myself, and I'm afraid I'm going to stab my partner. That seems a little bit more obsessional than there's an obsession of stabbing your partner, but then there's an ideation of stabbing yourself. So I would look at other symptoms in that context. Likewise, comorbidities. If there's comorbid major depression or mood disorders, or again, personality disorders, substance use, and you have symptoms associated with these other high-risk disorders, it could be more ideation, more of an ideation.
Mm-hmm. And in the behavioral differences section, you talk about approach avoidance versus avoidance. That's what I wrote down in my notes. What does two different terms mean?
So approach avoidance, I think that's referring more to the suicidal ideation, that somebody with suicidal ideations may approach those thoughts, whereas somebody with, or they could avoid them. Yes. So they may engage in self-injurious behaviors, preparatory behaviors, rehearsals even. So they could engage in more suicide-consistent behaviors. Whereas somebody with OCD, you wouldn't necessarily see them engaging in those behaviors. They would avoid anything that's potentially lethal. So avoiding the knives, avoiding any sharp objects, avoiding any dangerous situations. And you may see somebody with suicidal ideations doing that as well. But that's where it's kind of across that approach avoidance spectrum. It could be either.
And if you're a clinician, like I've seen kind of what happens when there's a misdiagnosis of SO versus SI. But if you're a clinician and you think that someone's experiencing suicidal ideations, what, like you mentioned, I think a Stanley Brown something. I don't know if that is research. Is that for a researcher? Is that what a clinician does? Like, what does a clinician do when their patient's experiencing SI?
For SI, I mean, the Stanley Brown is just a safety plan. So if it's clear suicidal ideations, then you would develop a Stanley Brown safety plan for when those thoughts come up. Here are some resources that you can utilize when these thoughts come up. Actually, we were very thoughtful to not include that in this study that we're conducting at Yale. We don't do the safety plan for those with suicidal obsessions out of kind of concern that we may reinforce those obsessions. If we were going to go through and say, when you have this obsession about harming yourself, why don't you do these that may kind of reinforce that cycle? But with suicidal ideations, of course, it's important to find resources that that person finds helpful to use in those moments.
Mm-hmm. But I guess the risk of misattributing these obsessions or ideations is providing a lot of reassurance right off the bat.
In what way?
Or not providing reassurance, but providing a plan that could become a ritual.
Yeah, but you would much, in a case like that, in the beginning anyway, you would want to, if I'm
caution.
If I'm meeting someone for the first time, like the initial interview, and they're talking about this, and if I have any doubt that it is an actual suicidal, intent, then I would much rather obviously err on the side of caution, right? And develop a relationship with them, make sure that they have a plan that, like Liz is talking about, and make sure that they're going to be safe. And then if this is something that comes up repeatedly, then we can look more carefully about, okay, well, maybe I missed that the first time and it's really an OCD symptom and we need to treat it like that. And any clinician who's been doing this stuff long enough, working with folks who have OCD long enough, has been fooled, not necessarily by that, but has been tricked into giving reassurance and only later realized, oh, wow, this is part of a compulsion and I need to stop doing that. So I think that's just kind of par for the course when you're working with folks that have OCD, that, sometimes you're going to, better to err on the side of caution. And you can always later on jump back in and say, okay, wait a minute, I was wrong. We need to treat this as an OCD symptom. Does that make sense?
Yeah.
Yeah.
And I think that's a good point to bring up. Erring on the side of caution is
oh my God,
always good.
Of course. Yeah.
But it's also really challenging when you err on the side of caution and you're a little bit too cautious, and that can be really stigmatizing and even traumatic for some patients. So some of what inspired research suicidal obsessions was speaking with so many people with suicidal obsessions whose obsessions were misclassified as ideations and involuntary hospitalized.
Yes, that's a great.
They've gone through just inappropriate treatment. It was really, really difficult for them.
Yeah.
Point where they don't share those obsessions anymore, or they don't trust their therapist anymore. So yeah, it's hard.
That's a great, that's exactly, it's a double-edged sword, because that's a terrible analogy for today, but it is, you got to be careful, because you don't want to, put the person through all this all that, but then you also don't want to send the message like, I really do think that you're suicidal, when in fact they're really not. And it's the same, someone who has like the OCD symptoms about pedophilia, right? You don't want to send the message, oh yeah, I really do think you're a pedophile, when they're not. So Liz is absolutely right. You need to be really careful. So err on the side of caution, but try to be careful in the first place so that you're not erring either way, which of course is, we do the best we can.
That's about the vaguest recommendation ever.
I feel like that for staying safe there.
It's a very common theme. You ask a simple question and the response from John or any other clinician on the show just is like, it's the most amorphous answer possible.
Be careful.
In psychology, the answer is always like, it depends. Right?
Yeah, see, that's why math is great. It's math. Just like 7.
Yeah.
So Liz, at the end of that paper, you have like a list of questions that, clinicians may be able to use. So, since it's so important that you delineate between these two things and you walk this fine line, Liz, I'm going to ask you first, what are some questions that you'd recommend? And then John, if you'd have some kind of like questions that if there's a clinician watching, they could probably use to help delineate.
Sure.
So I'm taking notes about some of these responses. Of these are guarantees. So again, it depends. It's not super clear cut, but some of the questions that we identified in that paper, they fall within this functional assessment framework. So we just want to know, what is the function of this behavior? So
what's a functional assessment? Is just looking at the function of the behavior? Is it like a scale thing? Is it a big test?
Just broadly, we're looking at the functions of these behaviors. So we just want to know what, I guess I don't know how else to describe it aside from what is the function of
I can jump in. So we want to know the antecedents. So what are the triggers of it, right? And then the specific, the behavior, what are they doing? And then the consequences of it. What happens afterwards? How do they feel? What happens around them? It's a functional, when you do a functional analysis, you take one behavior and you really do, you dive in and usually it's asking questions, but it can be behavioral observations, stuff like that.
So if we use that framework with suicidal obsessions, or if we just have suicidal thoughts in general and somebody with OCD, you can ask cognitively, how aligned are the thoughts with your sense of self to get at that? Is it egocentric, dystonic? Other than the suicidal thoughts, do you have any other intrusive thoughts to kind of capture? Is there other, harm OCD thoughts coming up? Affectively, what do you feel the thoughts? What emotions do you tend to have in response to the thoughts? When do the thoughts come up? Are they totally random and intrusive? Again, what's the antecedent here? Or do they come up when you're feeling really down? You failed an exam, you went through a difficult breakup, and now you're starting to have these thoughts. Behaviorally, have a thought. Are you engaging in a compulsion? Are you engaging in self-injurious behaviors? How often are you engaging in those behaviors? So if you're doing something potentially self-injurious, maybe once a day in response to the thought, compared to I'm continuously checking my body for self-injury, or I'm constantly calling my clinician to ask, do you think I'm at risk? Or I'm calling my friends or family members to ask them what they think. That seems to be a little bit more compulsive in nature.
Mm-hmm.
And again, those are just examples, so there's no right or wrong way.
I completely agree. And back to the functional analysis stuff. If these thoughts are only coming up like when the person sees, like a trigger, like a knife or something like that, then I think that's a sign often, because usually regular old suicidal ideations are going to be more kind of a general feeling rather than just provoked by certain circumstances.
Mm-hmm. You also wrote a little bit in the paper about scales, Liz, and how like scales can like the Columbia Suicidality Scale, I think it's called, can sometimes make it hard to delineate between the two. Can you talk a little bit more about that?
Yeah. So just generally, a lot of the assessments that we use for suicidal ideations are flawed. So they're especially reliant on self-report measures, which are problematic for their own reasons. But in this population, just looking at differences in obsessions and ideations, when we ask somebody, do you have thoughts of suicide? Do you ever think about killing yourself?
Mm-hmm.
I mean, somebody with suicidal obsessions or ideations will endorse those items on those measures. Likewise, some of the other maybe more specific questions, do you want to die? Somebody with obsessions who is especially uncertain may say, I don't know. And that may kind of trigger that rumination loop. So that's why it's really important to look at a whole framework and ask a lot of these questions, because even just some questions that I provided as an example, I don't think that we can rely on just those independently. But likewise, we can't just look at behaviors either. You have to look at all of these things together.
Mm-hmm. Yeah, I mean, if the scale is asking, do you think about killing yourself often? Then
yeah.
That goes for both populations pretty quickly.
That's right. Yeah.
John, do you have any questions before I say something about what someone said in the chat?
No, let's go to the chat, because I know there are a lot of...
Okay, I'm going to ask you guys this. I don't know if you have an answer. Lisa Walter at 1219 said, any thoughts on the 2016 Swedish study suggesting patients with OCD have a 10 times higher risk, I imagine, for suicide?
I have not seen that study. When we're talking about a 10 times higher risk, we need to think about that, because that looks really alarming. But remember that the risk of suicide in the general population is pretty small, thank goodness. So when we talk about a 10 times higher risk, we're still talking about a small number. But sizable relative to the general population. I mean, yeah, if there's been something that's been found in the literature, then I think it's something that's worth heeding.
Worth thinking about.
Sure, yeah.
To, I guess, take it into context, in the sense that you don't know higher than the general population. What sample of those with OCD are we looking at? Is it an outpatient population, an inpatient population, comorbidities? So there's a lot to consider there. But
yeah.
And then Deanna Garza at 1243, she wrote in a comment, "I'm beginning to wonder if I have suicidal ideation obsession. I think about it all the time." And my heart goes out to her. And I'm wondering if you guys have maybe something you want to say to her to help her figure out what might be going on.
You know what? We are having an alert about an armed and dangerous person on campus. And so I just received, I don't know if you can hear, there've been all sorts of sirens going off, and now I just got a text. We just had a very unfortunate event here 2 weeks ago, and people are running for safety. So my mind was just elsewhere. Sorry, but ask the question again, and I can.
Do you want to hop off, John? We only have 4 more minutes, anyways.
No, I mean we hopefully will be okay, but just heightened state of alert. Speaking of physiological responses.
Yeah, fair enough. I'm sorry. I hope everything ends up okay.
It's a thing these days. It's terrible.
The question, which now seems not as important, but someone said that she's beginning to wonder if she has suicidal ideation obsessions. Suicidal ideation. If you're someone suffering with OCD, is there maybe something you could suggest she think about or ask herself, or is maybe that, a rabbit hole that's not worth going down and she should speak to a clinician to figure it out?
Well, yeah, I mean, I think speaking with a clinician is always the best thing, and if you haven't already, have some sort of an evaluation, but also to think about like some of the things that Liz was saying before, right? Are there lots of compulsions around this thought where you're trying to dismiss it, where you're asking people for reassurance over and over again? That might suggest more an OCD symptom. If it's something where you've got a history of like acting on suicidal thinking or developing a plan or some sort of some sort of plan, then maybe that is something leaning more towards suicidal thinking. But either way, my thought would be to be in touch with a professional who can do an evaluation.
Mm-hmm. And Liz, before we wrap up, do you have anything you kind of want to leave with the IOCDF community?
Well, just kind of piggybacking off that comment, of course, it's important to talk to a clinician about the thoughts, but also advocate for yourself and, continue to express how you feel about the thoughts. I think that's so important to both advocate for yourself, but also to demonstrate, some of the nature of those thoughts. If you share with your clinician, I'm having these thoughts, and you just leave it at that, you're leaving it entirely to the clinician to determine. But if you can share a little bit more, again, about how the thoughts make you feel, when the thoughts come up, what you're doing with those thoughts, and being as honest as you can, I think that's probably the best approach to having that conversation with a clinician.
Mm-hmm. Well, thank you both for helping us sort through this complex topic. I'm going to wrap up kind of quickly so John can figure out what the hell's going on.
Well, I just want to say, Liz, I am really impressed, and I'm sorry that I'm not taking a grad student, because certainly you'd be an awesome match for my lab. But I wish you all the best. You're going to be awesome, and the field should get ready for wonderful contributions coming from you.
Yeah, Liz
Thank
is awesome.
Thank you so much. I appreciate it.
I hope we'll stay in touch.
Yeah, definitely. Thank you.
Yeah.
So the online OCD conference registration, it's the online OCD registration is now open. So if you want to register for the online conference, you can do that at iocdf.org/ online OCD Con. There's also a lot of other live streams, and you can find them all at iocdf.org/peace of mind. Okay, Brennan, now you can put up the banner. Thank you guys for watching.